Hi, so part 2 video, starting with number 6. So, um, this one is genetic metabolization and methylation. And so, um, as patients with EDS, I think a really common story that you'll hear are people experiencing medications not working as intended and even having the opposite effect as intended, or having a medication metabolize in and out of the body more quickly than expected, or maybe not coming out of the body at all. So, one class of medications that can be particularly problematic and contraindicated is a class of medications called quinolones or fluoroquinolones. They're strong, but they are still regularly prescribed broad spectrum antibiotics for pretty serious infections and illnesses. And these can cause serious and irreversible damage to the soft tissues, especially. And it can be important to know about these risks in these medications because a lot of people get prescribed these medications and they suffer from tendon ruptures and pain throughout their body afterwards, and it's they really regret not being informed of the risks and that they weren't warned that this could have happened to them. And not always, but a lot of times there was possibly another medication that it could have been prescribed that didn't have this high risk. A lot of people with EDS also have very metabolic issues with regard to medications and also with regard to things in their daily diet. And so with the chronic experience, it's helpful when possible to get a metabolic panel done to see like which things are maybe not at the right levels in your blood, and to know like which things you may want to try to get right. And it's also important if you can get genetic testing to see if to know like which medications may or may not work, because they do have a lot of testing available now, and knowing when you may have problems with things may be really helpful for you and help you avoid a lot of frustration and a lot of really awful side effects. So like some of the more common problems that people can have are problems with certain classes of psychotropic medications and anesthetics, or some analgesics, or even for some people some allergy medications. But there are lots of medications that people can have bad reactions to. Now, this is not to say to just avoid getting medications when you need them. No, like sometimes people really need medications, and it's important that you balance out risks and benefits and all of those kinds of things. Because even sometimes when a test is telling you that genetically something may not work for you, a lot of these things aren't 100%, and so sometimes you need, if you have a really severe issue, you may need to balance those things out. An extremely common thing too is there's a MTHFR mutation that's pretty common in EDS patients. It's actually in a majority of EDS patients so far. Who knows what will happen when we know how many people actually have EDS. But these mutations can lead to methylation problems with folate. And EDS patients can also have problems with processing other types of vitamins that are really important for them to take. So it's important to find out if you do have problems with methylation in your body. And so in some people, no, not always, some people it can cause complications with your diet and certain types of food, and if left untreated, it can greatly vary from person to person. In some people it may not affect them at all. In some people it can actually cause really serious problems. And sometimes it can help to take methylated versions of supplements to counteract these things. Um, but anyway, a lot of these things, like each individual processes and breaks things down uniquely, and so just knowing what things are at risk and knowing how to find those things out and knowing how to communicate really well with your doctor about when things aren't working or giving you problems, um, that can be really helpful. So, neurological issues. So in this one, we're talking more about central nervous system issues and other like peripheral neurological issues. So we're talking about neurological issues aside from the autonomic nervous system, because we talked about dysautonomia already. They're also pretty common in EDS, and they can be a little bit complicated to properly diagnose and understand due to the lack of research, and sometimes we can have a unique or atypical presentation of some of these things. So one common thing are migraines. Those are pretty common, but they may require more complex management and differential diagnosis, like ruling out other problems in EDS, because the pathway to them may be different from people who don't have EDS. Patients may have to rely on trial and error, and the treatments that they need might be a little bit different. So patients can also have a misdiagnosis of migraines when it actually is something like neuralgia, craniocervical instability, or Chiari malformation that's causing the symptoms. And these things are really highly underdiagnosed just in the general population, let alone the EDS population. And that can often render normal treatments for migraines ineffective, or sometimes those normal treatments can even make the problems worse if the diagnosis is improper. To complicate things a little bit more, patients can legitimately have migraines and still have other neurological problems as well, and that can lead to frustration and a false belief that the patient is having intractable migraines or frequent rebounds or things like that, and then they might take away the migraine treatment, and then things get even worse because they still are having migraines but have other things going on. So that's why this whole like underlying condition of knowing that you have Ehlers-Danlos syndrome and knowing what other things you have can be so helpful. But due to soft tissue weaknesses and injury, CCI and Chiari are suspected to be far more common in EDS than in the general population, and they also are suspected to be some of the drivers, due to their compression on the vagus nerve, of a lot of autonomic nervous system dysfunction. So this can be a neurological condition that interacts with that dysautonomia that we talked about in the beginning. It's also not uncommon for patients with EDS to experience some form of neuralgia or injuries, such as CSF leaks or other chronic pain in the head or elsewhere in the nervous system. And patients commonly report features of episodic dystonic episodes, or some kind of dystonia. And that's something that is coming out of research in France, and that is incredibly underdiagnosed here in the United States, and that's usually mislabeled as psychogenic disorders, pseudo-seizures, things like that. Many of the disorders are difficult to get recognized because even when appropriate testing is available, very few doctors are actually trained to diagnose or interpret the results. But being aware of them and figuring out these things can help you sometimes get the appropriate referrals and get the correct tests ordered when treatments are necessary. But it can also help you stay maybe a little patient and waiting for a really good doctor rather than trying to rush to one who may not be that great. So number 8, ocular issues in EDS. So patients with EDS can have a lot of problems related to the condition with their eyes. And I've heard a lot of things. So, one of the most common things, of course, is myopia, which is just being nearsighted and needing glasses. But there are many other forms of problems with the eyes that can happen. And so it's often important to develop good habits, like going in for regular testing, not putting off your eye exams for too long, because for a lot of these, earlier diagnosis can lead to earlier support. So people can have issues with their corneas. They can experience retinal detachment. Macular degeneration is a really common issue that can occur in EDS. And because it's the eye itself and the structures of the eye, rather than just the vision, that people really want to have looked at. Usually you want to make sure that you see an ophthalmologist instead of just an optometrist when you're getting an examination. It's not that an optometrist can't look a little bit and see like some warning signs of things, but you'll get a much better exam from an ophthalmologist, even though those exams are pretty intense and take a bit longer. Now, maybe you don't necessarily have to do that every year. I mean, I think that it sort of depends, like what kind of risks run in your family, things like that. But I would consider that in terms of getting your eyes tested as frequently as seems reasonable. Okay, oral and mandibular issues. So we are going to discuss other joint issues in a bit, but oral and mandibular issues particularly, I think, are important to discuss in their own category because they're a particular unique set of problems in Ehlers-Danlos syndrome, and they deserve special mention because a lot of patients with EDS have to deal with these kind of related problems, and they're really specialized issues. So for one, patients very commonly report TMJ or TMDD, and in and of itself can be a complex problem, and it comes with a whole host of considerations like having chronic headaches, interaction with craniocervical instability, pain while chewing, which can provide its own problems because it can mean that you're not breaking down food enough with amylase, and if you have other GI problems, that can cause and interact with enzyme deficiencies and other problems with swallowing and stuff like that, so you don't want to make those problems worse. You can have dislocation, you can have teeth grinding, and a whole other slew of problems. So if you can get TMJ treated, that's a really good and helpful thing. One of the unique features that a lot of people with EDS, especially hypermobility EDS, also share is a smaller than typical bite in their mouth that can lead to teeth crowding, and sometimes they can also have a loss of teeth or adult teeth never coming in. They can have other orthodontic and other severe dental problems. Their teeth can crumble, the soft tissues of the gums can be weakened, and so there are a lot of problems that are possible to have in EDS. Very few people have all of them, but there can be a lot of issues with that. And further, with a small bite, EDS patients have atypically high narrow palate in their throat and the back of their mouth, and so these features combined can lead to numerous dental difficulties. You may find that things aren't, like when you go to the dentist, that they're not fitting into your mouth properly, so the bites that they use are the x-rays or stuff like that. And so you may need to use child-size implements sometimes when getting dental procedures done, that might not be available at an adults-only practice. Um, and, in addition to that, when you're going to the dentist and stuff like that, you may have problems with anesthesia wearing off quickly, so you may want to make your dentist aware if you're having a lot of dental problems. And you may want to do whatever's necessary, really, to preventatively protect your teeth, knowing about these vulnerabilities and your gums, because, you can try to make sure that these oral problems are avoided and that your jaw issues are managed and all of that. And so that's just another thing to be aware of. All right, now moving on to pelvic and hormonal issues. So, just with a quick comment on a sort of anatomical thing, a lot of people report having pelvic floor and sacroiliac joint dysfunction, also known as SIJD. And they can also have uterine prolapse, pelvic inflammatory disease, hip problems, stuff like that. There are so many problems that can come, and I think we think about it more for women. EDS presents a little bit more seriously and severely for women. Men can have some of the physical issues here, and I think that there's just not as much research for men, and they can still have an awful lot of pain due to the anatomy. But women in particular, like with the uterine prolapse, stuff like that, they have a lot of other complications that can come. Polycystic ovarian syndrome, endometriosis, fibroids, those are all more common, or seem to be, at least so far, in EDS. And those can lead to an awful lot of pain and discomfort that gets neglected due to women's health historically not having been a priority, and particularly that women's health has sometimes been researched on male-only populations. So how do you get at uterine and menstrual-related problems or female hormonal problems if you're only doing research on males? Anyway, it's just something to realize that some of these things have been really under-researched until, a bit later in our history. So there are all of those kinds of things. There also seems to be a little bit more common report of thyroid issues so far, and certainly there are many other hormones that can correlate with pain issues. Now, which one causes the other, there isn't necessarily clear evidence of this. I know that there is an EDS pain doctor that's been pretty well known who's done some work clinically in working with helping pain patients by treating hormones, but we don't always know, right, what causal things are, because sometimes treating effects can help cause, or just things are correlating together. And so but yeah, there are certainly a lot of pelvic related issues that have to do with sort of an anatomical, I'd separate them into anatomical things, and then hormonal issues, separate, that are kind of separate, but since a lot of them, sort of, when we think about them, bioidentical hormones come from, that region of the body, that's another area. But certainly there are a lot of other hormones that do come from other places in the body, the brain, and are controlled by and can affect our autonomic nervous system. These are all really important things that, if we need to address them, that they're important that we have a great person. So Here ends part 2. Thank you.